Good evening, everybody, and welcome to the London Clinic annual lecture. We're very proud and pleased that the London Clinic support us and support you to come to this lecture free of charge, which is always appeals to our delegates. I'm Roger Kirby. I'm proud to be the president of the Royal Society of Medicine, and we've had interesting times during COVID. This lecture theatre was virtually deserted for 2 whole years, so it's lovely to see people back. I think we've got more than 200 people registered. There are a few filtering in from the back now, so we're going to have a great evening, and we're going to discuss a really important topic. Pancreas cancer is such a scary disease. You know, I know we were just saying the former master of St John's College, Cambridge, where I went to university, died of pancreas cancer not long ago. So many people I know have suffered from that disease, and it's so difficult to diagnose, often gets diagnosed late, so difficult to treat. The surgery is really big and difficult surgery. We've got some brilliant surgeons to talk about that. We'll be talking about chemotherapy, immunotherapy, and the future, because it is predicted. It's already the 5th commonest killer of cancer in the UK, globally too, and it's predicted to become the 2nd commonest cancer killer. And the reason for that is probably that other cancers are being treated more effectively, more aggressively. Colon cancer, breast cancer, lung cancer is falling because of smoking reduction. So pancreas cancer is a really, really interesting topic. And we're going to hear 3 experts talking about it this evening. I'm going to introduce them all, and then they can introduce themselves. Then we'll have an interactive discussion with 2 microphones, one on either side, so you can really ask them questions that are relevant, pertinent about the way this disease should be managed and the way it will be managed in the future. So we're going to hear about surgical developments in pancreatic cancer from Krish Menon. We're going to hear about pancreatic cancer from laboratory to clinic and back again from Hemant Kocher. And then Shivan Sivakumar is going to tell us, will there ever be oncological developments in pancreas cancer? Really important question. And we were talking before about the work he's doing in Oxford, which sounds absolutely outstanding. And then we'll have a panel discussion about 7:20 for about 20 minutes, where you get to ask the questions. And we'll have drinks next door. Thanks to the London Clinic. I see Al Russell. Where's Al Russell? I saw him there. Yes, thank you very much, Al, and the London Clinic team for supporting this. So I hope you'll all join us afterwards, where we can talk more about the subject that we're covering tonight. So with no further ado, our first speaker. Thank you very much. Krish Menon. There you go, Krish.
Good evening, and thank you for the invitation to come and speak at the Royal Society of Medicine. It's been some years since I came here as a fellow to participate in a prize presentation at the RSM. So thank you for the invitation from the London Clinic to talk on this very important subject. I think it's a lot to cover, so I'm going to try and whiz through what has happened and what had happened in the past in pancreatic cancer, and then I'll hand over to the people who are going to talk about the work that's been done in the laboratory and then from the oncological perspective. So I'm going to stick purely to surgery as far as I can. So I'm going to dedicate this lecture, and I've taken permission from the Royal Society of Medicine, to my mentor, Professor Tempton Udwadia. He sadly passed away on the 7th of January, and he was a pioneer in laparoscopic surgery, a mentor, and more importantly, a great human being. And he always believed it's more than just being a surgeon. So with that, I'll start the talk today on surgery for pancreatic cancer. Now, when you talk about pancreatic cancer, I always love history. Where did it all start? What made pancreatic surgery happen? And then I'll touch on what the current standards are for pancreatic angiodenectomy. Should we or should we not do vascular resections in pancreatic cancer? In other words, take out bits of blood vessels that are involved. And I love this bit because there's always fads in surgery. Surgeons always like a bit of fashion. And what are the fads currently in pancreatic cancer? Touch on those 3 a little bit and my views on it, my personal views. And then obviously the much debated topic on whether or not should we use the minimal access approach for pancreatic angiodenectomy. Is there any evidence for it? And then talk about complications, but I can't talk about all the complications of pancreatic cancer because as surgeons would say, we get very few. But I'm going to focus on pancreatic fistula, which is the critical complication that determines whether a patient does well or not. And then this is some of the work that we did in Leeds, some of the pioneering work on interpretation of margins in pancreatic cancer following resection, and some of the novel technologies that we developed at King's in using that knowledge on margins and trying to treat pancreatic cancer in a slightly innovative and novel way. And then, as always, talk a bit about where we're going from here. And I'll then hand over to Hemant and Shivan. So as Roger's already alluded to, pancreatic cancer is one of the leading causes of cancer-related death in the UK, and around 1 in 71 patients will get pancreatic cancer. So it is important that we have a plan as to how we're going to handle this disease. Pancreatic cancer, you can have pancreatic head cancer, then you get what we call peripancreatic cancers. Peripancreatic are those that are involving the ampulla of the pancreas, the distal bile duct, or the second part of the duodenum. Now, all of them are clubbed together. And the first and the second bit, the treatment is the same. The surgical treatment is a Whipple operation, as we'll come to in a second. So therefore, I will focus on that. We're not going to talk about pancreatic neck, body, and tail cancers, which are a completely different entity. Then you've got the pancreatic neuroendocrine tumors, some much more slowly growing tumors with a slightly better prognosis, and the cystic neoplasms of the pancreas that have actually caused a significant dilemma to surgeons and clinicians in how we manage these patients. And unusually, you do get metastatic tumors from the pancreas from either breast cancer, kidney cancer, or bowel cancer. So the anatomy of the pancreas is a challenge because it's located retroperitoneally and was therefore a fearsome organ to target when you were a surgeon or anybody who tried to intervene in the pancreas. And it's not surprising that it was said that God placed the pancreas in the back as he didn't want anybody to mess with it. But people did mess with it. And that's where history comes. So it was actually Alessandro Codibilla who first attempted taking out the head of the pancreas. It was quite a challenging thing in the 1800s to attempt such a big operation. Unfortunately, as expected, it was not successful because we will talk about why in a second. However, the person who actually did the first successful operation was Walter Kausch, who never gets a mention. And the reason he doesn't is because he did it in 1909, some 30 years before Alan Oldfather Whipple. But Alan Oldfather Whipple, who did the Whipple operation, was a person who published his work. And that's what we talk about, publish what you do. And he had a successful outcome from the pancreatic duodenectomy. So often it's known as a Whipple operation, but the purist surgeons, some of them in the audience, will call it the Kausch-Whipple operation. So, and then obviously it took on and people started doing it, but more often than not, people were scared of doing it in one stage. So they did the resection and did the reconstruction as a second stage. So you can understand the kind of inhibitions and the trepidation with operating on the pancreas. So why is pancreatic cancer a challenge? As you can see here from the picture that we've got, the pancreatic cancer, the pancreas tumor is located in the head of the pancreas, but look at the clockwork around there. That's the portal vein, the superior mesenteric artery, the IVC lies behind that. And then you got the duodenum and the bowel to contend with, a difficult organ to tackle at best of times. And then when the tumor expands and then starts to involve these blood vessels, you get what's called a borderline resectable pancreatic cancer, which then makes it even more challenging. So what's the spectrum of disease that we see in pancreatic cancer? Sadly, we don't see much of this. Of every 100 patients you see, I can operate on 15, maybe 20 at best. Vast majority of them go into the upper spectrum, which is if there is venous involvement, there's partial venous involvement, or there's arterial involvement, arterial encasement, or sadly, distant metastases. And that is curtains, because you can't do much when it's pancreatic ductal adenocarcinoma. So what is the Kausch-Whipple operation? The Kausch-Whipple operation does involve removal of quite a bit of tissue. So that, as we said, was the anatomy of the pancreas. So it involves removal of the head of the pancreas, the duodenum, all of the duodenum, the gallbladder, the bile duct around the outside, and all of that then has to be put together again. So if you're doing a classic Whipple, as they call it, or the Kausch-Whipple pancreatic duodenectomy, you join the stomach, where part of the stomach's been removed, the pancreas and the bile duct, and all of that can be done in what we call the Y loop or the Roux-en-Y loop. It's a complex operation, takes 4 to 6 hours to do at best, if it all goes smoothly. Then you got the innovation that happened early on, where people said, why do you need to take out the whole of the stomach? Why not take out part of this, leave all the stomach, because the outcomes might be better. So that became the pylorus preservation Whipples, where you preserve the pylorus, and the aim was the stomach empties better. And as the stomach empties better, you get better functional outcomes in the patients. So they lose weight less after surgery, and they actually maintain their physical status. So pylorus preservation became a very popular operation. However, what's the evidence? Is there a difference between doing a classic pancreatic duodenectomy versus a pylorus preservation? This is the best data that's available. It's a Cochrane review that came from none other than Markus Buechler and his team from Heidelberg. And what they concluded, I won't go through the whole paper, was what is the standard pancreatic duodenectomy? It involves removal of what we talked about in terms of tissues, but a standard lymphadenectomy. In other words, take out the lymph nodes in the area, don't have to be too radical about it. You do remove all the tissue in the neural tissue in the triangle, and I'll talk about the triangle because it's one of the fads. And then, was there any difference whether you did a classic Whipples or a pylorus preserving Whipples? And you can see no difference in terms of survival, mortality, or morbidity. However, the classic Whipples had better emptying of the stomach, strangely. So while you thought the pylorus preservation would be better, actually it was the classic one that had better emptying. The pylorus preservation might reduce the operative time, intraoperative blood loss, and blood transfusions. So finish with that one. That's the main operation done. When the vessels are involved, should we or should we not operate on these patients? And as we said before, these are classed as what we call borderline resectable pancreatic cancers. Sorry. And that's what we're talking about. That tumor is involving either the portal vein or the hepatic or the superior mesenteric artery, or above there, you got the hepatic artery that courses there. So when these are borderline resectable pancreatic cancers, there are significant surgical challenges because you've got to be able to resect these vessels and rejoin them back together, because you cannot do without the portal vein, you cannot do without the superior mesenteric artery. The portal vein supplies blood to the liver, the superior mesenteric artery supplies blood to the entire gut. So you need to be able to do that. So should we resect them or not? Now, portal vein resections can be either small resections. I don't believe in this form of resection. I'll tell you why. A short segment where you got a tube and you take a bit of the tube and then join the two tubes back together. And that can be done without using a graft. And when we say graft, it means using a vein that is available from a deceased donor, and you can use that. And as transplant surgeons, we're lucky. We've got them in our fridges all the time. Or you can do it with a graft, and the graft can be with a cadaveric graft, or you can use a Dacron material. Arterial resections. Now, this sounds very complex for those who are lay in the audience. It means it's an anatomical variation of the hepatic artery where it courses more closer to the pancreas and can therefore be involved. It's not that much of a challenge because we can actually resect and rejoin it. Common hepatic artery and the mesenteric artery are much more challenging to do. And as you can see here, venous involvement, small segment, we don't do that. I would prefer that you put a patch there, and that doesn't then narrow the portal vein. That's removing and joining it straight away. That's with a cadaveric graft, and that's with a Dacron graft. So that's just showing you what we can do. We can do all kinds of things in surgery. We can take out bits of vessels, we can join them together. But as Shivan, who's sitting and frowning there in the front, will say, is it the right thing to do? Is it oncologically the correct approach for a tumor that's involving the blood vessels? So should we do vascular resections? And this is, again, a fantastic study that came from the French group. And what they concluded was that if you've got a borderline resectable tumor, please give them neoadjuvant chemotherapy. Neoadjuvant in the sense, give them chemotherapy, try and downstage the tumor, because then if you do believe, as a purist do, that pancreatic cancer is a systemic disease at the outset. So if it's a systemic disease at the outset, you have to tackle it with neoadjuvant chemotherapy to try and downstage, and then you'll get better outcomes. And therefore, you can then do venous resections for limited resection or even end-to-end. If you've got arterial involvement, we'll talk about that in a second. But if you've got a planned venous resection, you've got to downstage it, and that will improve your chances of an R0 resection. What about the hepatic artery? Again, if you use neoadjuvant chemotherapy and you can get the tumor away from the artery after a restaging scan, then you can operate, otherwise not. Superior mesenteric artery is much more harder to get clearance from, but if you do get response after chemotherapy, you actually should ideally do a frozen section. In other words, biopsy the area at the time of surgery, make sure there's no cancer there before you attempt a full operation. Otherwise, you're not going to advantage the patient, you're going to disadvantage the patient. So here we come to our fads in pancreatic duodenectomy. So what is the first fad? Artery first approach. Now, there have been about 1,200 publications on the artery first approach. And what it is it's something that we've always been doing. And people, again, surgeons in the audience will know that when you got a tumor that's involving the portal vein, you probably need to do this approach, but otherwise not. And I'll actually illustrate to you what it means. So what is an artery first approach? What they're talking about is the superior mesenteric artery. As you can see here, that's the pancreas, and that's the superior mesenteric artery. And that's the area they're talking about to get into. So the first stage is you retract the portal vein to your left, and then you expose the superior mesenteric artery. Then you divide the pancreatic duodenal veins and start to dissect the superior mesenteric artery. You clear all the tissue, as you can see here, to the right of the SMA. So what it is basically you're being radical and taking all the lymphatic and nervous tissue to improve local clearance of the cancer. That's what you're trying to do. So in the end, when you completed it, you can then do your portal vein resection. So the only time this is actually indicated, I mean, otherwise you're doing it all the time. But specifically, if you got a portal venous involvement, do not attempt that without actually clearing the artery, because it's a waste of time otherwise. What is the evidence? So does an artery first approach improve the resection? There you go. That's the evidence. And you can see here, R0 resections are not different. Postoperative complications, no different. Standard versus artery first approach. So my conclusion in this, or take home message, is artery first is only relevant when you're doing a pancreatic duodenectomy with portal vein resection. Then comes the mesopancreas. Do you ever think pancreas had a mesentery? I didn't, but somebody came up with this, and another 500 publications on mesopancreas. And I'm not being too, I'm not belittling evidence, but sometimes you start to think, are we reinventing things which are already existing? So mesopancreas is the tissue that exists between the superior mesenteric artery and the head of the pancreas, which we always used to take out. But somebody coined the term mesopancreas, and I would say that has always been removed. And most good surgeons would always do that right from the beginning. This, I think, is a valid one. So this is one fad, and Buechler is Marcus Buechler, not the Bermuda Triangle, but the Buechler Triangle. And what is the Buechler Triangle? So the Buechler Triangle is a tissue between the hepatic artery, the portal vein, and the SMA. And I think this is relevant. This, if you don't achieve, and a lot of people were not or were worried about doing this and not doing it adequately, but if you do that adequately, it does get you better local clearance. So moving on to complications. So I said I'll focus on one, which is a pancreatic fistula. So there are various ways you can join the pancreas back together. You can join it to the bit of jejunum, there you can see that, or you can put it into the stomach. So again, there was a lot of controversy, a number of studies have been published. Is it better to do one or the other? And I think if you look at the evidence, again, no difference, okay? So whether you do a pancreatic jejunostomy or a pancreatic gastrostomy, there is absolutely no difference. So either is acceptable, and in your own hands, what is safer is better. So if you look at again, they've classified fistulas, a number of publications on this, but this is the first ISGPF, which is the International Study Group on Pancreatic Fistula. And this is key, I think. Soft pancreas, which happens to be the high risk one, and if the duct is not very large, when you join these together, there is a higher risk of leakage of the pancreas. And we all know leaks, gets infection, higher risk of bleeding, higher risk of length of stay and complications and mortality. So which is why it's important. So you can grade them as A, B, or C, and that was in 2005. But as you can see, the developments have been, we moved on. And in 2016, A doesn't exist anymore. That's just a biochemical leak. B and C is the worst, where you can get sepsis. How do you reduce fistulas? So again, we've been innovative, and some of the people are joined in from the other parts of the country. What we've developed or we've used is the Archimedes stent, which is a biodegradable stent that can actually be put across the pancreas when you're doing the joint to reduce your risk of fistula. It's a pilot study that's being done. Data is still not out there, but it's something for the future. What about the surgical outcomes? This is evidence, okay? This is clear. Important graph. When you do 1 Whipples, your mortality is high. As you go down, and if you do more than 16, your mortality drops to less than 4%. So there's no question, there's a direct relationship between surgeon volumes and outcomes. So if you're a pancreatic surgeon, you have to achieve a certain number to be good at doing this. Go back to the slide of Cordivilla and Walter Couch. All of that was because you need to do a number of them to get better at it. So minimal access. Now, I must have been young, I must have been mad. And in 2005, 23rd of November 2005, I did the first lap total pancreatic duodenectomy in the UK. And I was quite convinced at the time that it's the right thing to do, and we kept on doing it. But as you can see, it's a long operation. People do fall asleep. And it was tiring for the surgeon. And we published on this as well. We then went on to actually do an oncological comparison of laparoscopic versus open. Are we doing the right thing for the patient in terms of cancer clearance? And we actually showed that there is no difference. However, the most important study that came out was a leopard trial, which was from the Netherlands, and they actually looked at lap versus open, and the study was stopped, or the trial was not completed because of a higher mortality in the laparoscopic group. So that is where we stand in terms of evidence for lap pancreatic duodenectomy. We've just completed the European consensus meeting, and there'll be more data coming out on this. And I was lucky to be one of the invited experts for this. Margin interpretations is the last bit of the talk. And it is something that's close to my heart because this is something that we asked many years ago, back in 2000 in Leeds. Why is it that we talk about a high R0 resection but get poor outcomes? Something doesn't add up. If we are doing a good job surgically, why is it that the patients are dying still within 5 years, 5% 5-year survival? So the question was, there's a clear lack of correlation between pancreatic head cancers and clinical outcome? And are the R0 resections really R0 resections? That's the question we asked. So with our pathologist, Caroline Verbecki, we changed the protocol from longitudinal slicing to axial slicing. And what we did was we inked the margins, the anterior, the posterior, and the SMB groove, and then combined that with axial slicing and showed that actually, if you looked at this in detail, you can actually see the tumor encroaching the SMB margin there, and your interpretation of margins is much more different. And when we did this on our group of patients, what we showed was that 85% of the margins were positive when you looked at it hard enough. So there the penny dropped, that the true R0 resections did do well, but most of them were R1. That's why they didn't do well. But did the world believe us? No. They said, you can't be serious. So most of you guys are poor surgeons, and that's why you're getting bad outcomes. So we had to then do a prospective study, which we did, and we published that as the Leeds protocol. And as you can see here, as expected, lymph node positivity and vascular involvement were all important factors, but the most important one was the resection margin. And that was translated in terms of survival as well. And we concluded and published this as a Leeds protocol, where we showed that if you use the standardized protocol, you're much better at interpreting margins. Based on this knowledge, we then had to convince the world. And who did we go back to? The slide I showed before, Marcus Buechler, who's a giant of pancreatic surgery. He did the exact same protocol and came to the conclusion most pancreatic cancer resections are R1 resections. So surgically, have we moved forward? Maybe not, a little bit in understanding the tumor and operating on them. So when you look at resectable cancer, if you are at a higher risk of margin positivity, is there any way we can actually reduce that? And that is where it came to IRE, which is nanoknife or irreversible electroporation. And we thought, can we apply IRE to the margins and see if we can reduce margin positivity and thereby get better local control? So we went all the way to my hero's hometown, Muhammad Ali, in Louisville, and we worked with Rob Martin, who is one of the pioneers of IRE in the US, and learned the technique and came back and decided that for resectable cancers, let's try what we call margin accentuation. And that's what we did. So the surgical strategy was with minimal mobilization of the pancreas, do a scan, apply IRE to the margins, and then proceed with the pancreatic duodenectomy. And as you can see here, that's what we did in terms of the technique. We did it to the neck, we did it to the superior mesenteric vein margin and the posterior margin. And we finished and concluded that actually, if you look at the results, the margin accentuation does reduce your margin positivity. We then proceeded to doing a pilot study at King's, which is a MACPI-1 study. And that again concluded that with the primary outcome being a reduction in margin positivity and secondary outcomes looking at complications, that there was a clear evidence that when you look at margin positivity, there was a reduction in the posterior margin in the MACPI-1 study. We are now proceeding to MACPI-2, which is the next study, which is going to be a multi-center study. But what we showed was that we could safely do IRE to the pancreatic margins and reduce margin positivity. So the future is again MACPI 2 followed by neoadjuvant studies that are going to combine this. And as you can see here, if you were to summarize all this together, pancreatic angiodenectomy for pancreatic ductal adenocarcinoma, you have to believe is a systemic disease at the outset. A standard pancreatic angiodenectomy is well defined. We talked about the triangle, which is really the important fad that you have to take home. Vascular resections have to be combined with a neoadjuvant approach. And an artery-first approach is relevant for portal venous involvement. Borderline resectable pancreatic cancers always need to be considered for neoadjuvant chemotherapy. There is no evidence at the moment for minimal access pancreatic angiodenectomy, and IRE or nanoknife for pancreatic cancer is under evaluation. And we are currently taking on a pilot study at King's to do neoadjuvant protocols for resectable pancreatic cancer. Ongoing research is mainly into neoadjuvant strategies, and we'll hear from Shivan later on. There is no doubt that biology is a king in pancreatic cancer, and it's more relevant to pancreatic cancer than anything else, where you can try what you want, but ultimately biology is the king. And I think it's important to develop a good team when you're delivering this kind of a service. I was lucky to have a very good team at Leeds and now at King's, and that's our staff at Dawson Ward in the bottom at our pancreatic cancer November month, which is a pancreatic cancer month. So I'd like to thank you for the invitation. I whizzed through quite a lot, and I'm happy to take any questions at the end. But with that, I hand over to Hemant, who's a good friend and has done a lot of pioneering work in research into pancreatic cancer and how to take this from the bench to the bedside. Over to you, Hemant.
I hope you can hear me. So nice to see so many of you here, very many familiar faces. So thank you for coming. And I must also thank London Clinic team here, as well as the Royal Society of Medicine for giving us the opportunity to talk about the work which we have been doing. Before I go into the work, I also want to point out that London Clinic does fantastic clinical research, and there's a clinical research email, which is very self-explanatory if you want to do clinical research at the London Clinic. So the topic is about biology is king. You heard about it, and how do we study biology better and make a difference for our patients. So I'm going to talk about the interface between the laboratory I work at Barts Cancer Institute and the hospitals where I work. So we want to study biology, and I think there's no place better than to study the normal pancreas. So here we have a very juicy glandular organ. It contains the exocrine pancreas, which is what we're going to focus on today, forms of acini and ducts. The endocrine pancreas I'm not going to talk about, but also the supporting cells, which I'm going to focus on. Very many types of supporting cells, vessels, nerves, but also fibroblast, which gives the basic architecture to the pancreas and supports the pancreas and forms less than 4% of all the cells. But as the disease comes, it becomes important. So here is the picture of pancreas cancer. The epithelial component, the cancer component, is very small. The vessels are almost gone. And most of the cancer actually is the scar tissue, the supporting tissue, which I told you about. So it's desmoplasia, fibrosis, or stroma. And we want to study stroma because, having studied cancer for the last 40 years in the laboratory, we have not made much progress. So my laboratory is focused on understanding stroma for diagnosis, early diagnosis of pancreas cancer, as well as treatment of pancreas cancer. So we've been focusing on desmoplasia and how it may talk to the cancer, but also how it may talk to the immune cells or the blood vessels. And a number of doctoral students, some of whom are in the audience, and postdoctoral candidates have spent years and years studying this to provide robust evidence so that then we can test this hypothesis in form of clinical trials. And I'm going to present today some of the slides from the clinical trial published 3 years ago on the StarPack clinical trial. But before I go on that, I want to summarize the work of many years of this study from various students with the help of some cartoons to try and keep it simple because it's a public lecture. So we already know from different laboratories, there's a lot of crosstalk going between different cells in the pancreas. So this is a cartoon of an acini. There are many acini. The green line on the acinous cell membrane depicts one of the signaling molecule, and there are many signaling molecules. The duct does not have that many signaling molecules. And they are all kept in order with this intervening cell, which we really don't see under the microscope unless you look for them, the stellate shapes or star-shaped cells, which in you and me will store vitamin A. So one of the few vitamins which is stored in our body is in the stellate cells. And the stellate cells give signals, many signals, to all these ducts and the acini. And these are some of the signals which we have been studying in the laboratory. So now in cancer, what happens? So this is disordered cells, and you can see the signal is now amplified. It is present not only at the membrane, but in the cell body and in the nucleus. So it's gone up to the nucleus, and that gives the cells a signal to proliferate. And they recruit these stellate cells and make them into a henchman, the myofibroblast. And this myofibroblast in turn proliferate and lay down the extracellular matrix, causing fibrosis. And they are tracks along which cancer cells can then travel along, invade, migrate, and metastasize. And all this is happening because the same signals which were being used by the normal pancreas is at a very heightened flux. So the same signals are being used at a very amplified manner. And our hypothesis was very simple, that in these stellate cells or myofibroblasts, if we can restore the vitamin A depots, may we convert the stellate cells into the good stellate cells, which can keep the house in order. And surgeons, gastroenterologists in the audience will know patients with pancreas cancer, because they don't have pancreatic juice or bile juice flowing into them, they are lacking the fat soluble vitamins. We treat the vitamin K deficiency because we don't want patients to bleed, but we ignore the other fat soluble vitamins. So we could show in our laboratory that indeed, at least some, if not all the myofibroblasts, we could convert into a quiescent form. This in turn reduces the flux or the signal to a normal level. There are many such signals. And as a result, the cancers now is not able to proliferate, we are able to control the cancer. And this gave us enough proof in principle to take this into clinical trial. So the STARPAC clinical trial was a phase 1 clinical trial, and the STARPAC 2 is the phase 2 clinical trial, which is currently underway. And this has been made possible due to participation by many patients across many institutions and a whole range of clinicians, scientists, statisticians, and experts in various fields. So STARPAC was a pioneering trial because it's the first time we could target the stroma. So stromal targeting in pancreas cancer. We were combining the standard chemotherapy, which is gemcitabine and nab-paclitaxel provided by Celgene, with all trans-retinoic acid, a metabolite of vitamin A, as a stromal targeting agent to understand whether we can achieve a maximum tolerated dose. The principle that the more chemotherapy you can give, the better it is. But increasingly, we understand that actually it may not be true, and maybe we need to give less chemotherapy so that it's an optimal biological dose. So we wanted to understand that, but also get some signal on whether we can reduce the tumor and make it better. So this is the regimen. So you can see patients undergo many cycles of chemotherapy, and Shivan will be talking about it a little bit later on. A typical cycle lasts for 4 weeks. The weeks are here, divided into days. And normally we would schedule gemcitabine and nab-paclitaxel on a weekly basis, say a Monday, and then you'll get a couple of Mondays off before you go to the next cycle. So we schedule the retinoic acid supplementation only when you were having chemotherapy and give a patient a break. And that was important because retinoic acid, when given tonically all the time, can induce metabolism, and therefore you can decrease the levels of retinoic acid in your serum. So we also conducted a lot of pharmacokinetic, pharmacodynamic studies. We wanted to understand how these assessments could take place. In order to do that with the minimum number of patients, we made an innovative clinical trial design called a Bayesian continuous regression model. For simplicity, I've called it a STAR-PAC trial design. We screened 33 patients, of which 27 participated and others failed the screening. And we gave them the medicine at various dose levels, and we achieved a maximum tolerated dose. We continued that further and got an optimal biological dose, which was the recommended phase 2 dose. We could achieve that with very few patients. So we are very grateful that, that this could happen very rapidly. So this is a swimmer plot, tells you about how patients fared over a period of 12 months. You remember the median survival of these patients with advanced pancreas cancer is 6 months. People received various dose levels and they are colored accordingly. People were on chemotherapy, and once they finished chemotherapy, they were followed up. And we could see for the first time, we could reach a 1-year survival, just double the survival, which we have never been able to do before. But obviously, this is small patient numbers, so we really need to do that in a phase 2 trial. But the key thing for me was to understand whether there was a biochemical response. So here is a standard tumor marker, which we use, CA19-9, on a logarithmic scale, because there's a wide variation from 10 to 100,000. You can see a reduction, but you can't appreciate it very well. So if you were to normalize the baseline level to 100%, now you can see that within 2 cycles, you get a significant reduction in most patients. But there are 4 patients which are put in colored lines where there is a rising CA19-9 at some point or the other. So these we would call non-responders. So in order to determine the optimal biological dose, we wanted to make sure that the vitamin A levels did not drop as a result of giving ATRA all the time. And you can see the vitamin A levels remained similar across the various cycles of chemotherapy. And when you look at the progress of vitamin A per patient, you can see with those colored lines, all those non-responders, which are colored over here. And you can see, you can make out that those patients were having either a very low vitamin A level or there was dropping vitamin A level. So if we were to do a regression plot, this is what it looks like. Patients who were responding had a constant vitamin A level, and in fact, it was within the FDA recommended dose or level. And the patients who did not respond had a dropping vitamin A level. So determining the right patient and giving them the right dose would be the key in the phase 2 trial. This is another evidence that the vitamin A or ATRA was given at the right dose in the right scheduling. So you can see the pharmacokinetic graph of ATRA over the first 5 hours after taking the tablet, how the levels rise in the serum and they fall within 5 hours. The most important thing is at the beginning of each cycle, the levels reach the maximum dose at the same level, suggesting that there was no enhanced metabolism of all trans-retinoic acid. So we drew some good conclusions from this pioneering trial. One was that the adaptive continuous regression model trial designs were efficacious, safe, that the STAR-PAC regimen which we had designed was safe and tolerable for patients with pancreas cancer. We had a recommended phase 2 dose, and the ATRA pharmacokinetics were unaffected. We could also see that the STAR-PAC regimen may be efficacious. So what we saw in the laboratory may actually be true. We found an interesting finding that there was reduced neurotoxicity, which is very important for these patients where we received nab-paclitaxel and gemcitabine for a long time. They get a lot of side effects. We could demonstrate for the first time that we could target stroma, and we have pharmacodynamic readouts. So obviously the next step is to do a randomized controlled trial. That's currently undergoing. We hope to recruit 170 patients in patients who are having locally advanced pancreas cancer. You heard about from Krish Menon, those with arterial and venous involvement. We want to make sure that they are biopsy proven so that we're not taking in to consideration any of the peripancreatic tumors that you heard about. We will randomize them 1:1 with these stratification factors using a minimization statistical technique to equal numbers with or without all trans-retinoic acid, to understand that whether we can improve the progression-free survival and therefore the overall survival for these patients. Whilst doing that, this is the first time we'll be able to understand whether the locally advanced pancreas cancer has a different genetic, and we are going to study that with the help of ARGO or ICGC. And we hope to develop a lot of biomarkers using our national tissue bank. So the next part of the talk is to talk about the National Tissue Bank, which we are very proud to host at Barts. And London Clinic is a proud participant of this Pancreas Tissue Bank. So the Pancreas Tissue Bank funding is from Pancreatic Cancer Research Fund. It's got a management board and an operation board. And there's a coordinator who really coordinates everything which goes on in the tissue bank. And there's an independent tissue access committee. So if any of the researchers are in the audience wanting samples or data from a tissue bank, you have to ask the coordinator. The coordinator looks at the central resources, and there is bioinformatics, data management, sample management, and quality assurance, which is taking place at Barts. But most importantly, there are many key centers across the country, including London Clinic, which participate in getting recruitment for patients, samples, data. And this is all governed by the Human Tissue Authority and various policies of different universities and NHS Trust. So the tissue bank is already operative in these places, and I'm very proud that we are working with many influential, dedicated principal investigators. The most important people are all the doctors, nurses, scientists of various forms who are participating at each of these sites. I could not name all of them, but out of the 80, I've named about 40 of them, and that's a very big endeavor which is taking place. I'm very grateful that all of them are participating in this to enable research. So how does it enable research? Well, researchers apply for this data or samples, and you can see how the research has been fulfilled with a daughter tissue bank called the Barts Pancreas Tissue Bank, and the mother tissue bank opened only 2 years ago, and you can see a number of applications which have gone through. People submit an expression of interest, and most of them go to open a full application. The bottleneck is awaiting the researcher for further information, but once you're approved, you can get initiated very quickly. There are ongoing requests are fulfilled, data is returned to the tissue bank, and then we complete or close, and then they go on to publish their information. So you can see out of the 70 or 85 or so research activities, 23 have been published. And this initially started, of course, in London, across UK, but now we are having global impact through our National Tissue Bank. And this is the world's first, and I must say still the only National Tissue Bank for pancreas cancer. And this has made an impact already. There are a number of people. I'm very proud that we have helped a number of researchers further their research aims, bring new diagnostics, new treatments for pancreas cancer, which are now being tested in clinical trials. And for a researcher, it's important that you get onto the cover of the journal. We will never get into the time or life, but I think we are very happy to get on the cover of these journals. So how is this tissue bank going to help patients? We are developing new diagnostic tests. We are helping researchers globally to develop new treatments. And we are sharing information. And you can see all of that in the number of websites which are listed over here. And I'm sure you'll want to hear more about chemotherapy. So I'm going to invite Shivan Sivakumar, who is a medical oncologist at Oxford and who's recently joined London Clinic. So Shivan, come along.
Great.
Thank you.
Great. No, thank you very much. No, it's genuinely an honor to follow those two fantastic talks. So not many people know this, but I was actually a medical student with Hemant in 2006 on his rotation, and it was actually working with Satya Bhattacharya that I really got interested in pancreatic cancer. And actually, I was also an FY1 with Krish Menon as well. They both still look the same. And also, I just wanted to extend my thanks to the RSM for hosting this, especially Jules Wendon asking me to talk, so thank you. I was going to say, I'm not really going to talk much about chemotherapy. The headline is, it's not great in pancreatic cancer. And I really wanted to kind of look forward to where we're going in this disease. I mean, I've titled this talk, Will There Ever Be Any Oncological Developments in Pancreatic Cancer? And, you know, I wouldn't be standing here if I thought the answer was no. And I'm genuinely quite excited about where the field is going. So my name's Shivan Sivakumar. I'm based in Oxford. I've recently started in the London clinic too. And I mean, this is a slide which is well known to many patients, not many patients, many researchers in the field of pancreatic cancer. Where really, you know, the 5-year survival of different cancers over the span of 50 years, you could see has significantly improved in the UK. And there are these cancers languishing at the bottom, with pancreas cancer, unfortunately, bottom of the league table. So there's clearly a great clinical but scientific challenge to improve this. So this is kind of my day-to-day job. So one slide on chemotherapy. As you could see, the response rates and the actual survival benefits from giving these treatment modalities aren't great. You know, the mainstay is chemotherapy. There is some remit to giving immunotherapy within this disease, but only in 1 in 200 patients who have a particular syndrome called Lynch syndrome. We've had some attempt at targeted therapy in pancreatic cancer, and as you can see, it's given a 2-week survival benefit over chemotherapy. So, you know, we kind of need to do better. This is an American slide. You know, it's an American slide with the optimism at what happens at diagnosis where everyone else is alive. But you can see that actually in stage 1, 2, and 3, where patients have resectable disease, I mean, the survival actually diminishes pretty quickly. And stage 4, where patients have metastatic disease, even the 1-year survival is pretty abysmal. Now, I do take some optimism from this slide, because I think, to start off with, oncologically, we're going to do better if we capture people quicker. So in Oxford, I run a team which predominantly looks at using big data to try and help infer, you know, insights into pancreatic cancer. So here's some data from a collaborative project that's now been published with a colleague of mine who's a GP academic. And what we did is we took 28,000 patients' healthcare records from primary care with a diagnosis of pancreatic cancer, and we looked at 250,000 healthy controls. And what was clearly evident, and we stratified them actually into 3 groups. So patients with a diagnosis of pancreatic cancer where they've also had diabetes as a presenting symptom, patients who have had long-standing diabetes, and patients where there's been no glucose intolerance. And the bottom line is that patients have started to lose weight up to 2 to 3 years before diagnosis. Furthermore, 40% of patients' blood sugars are completely off 1 to 2 years before diagnosis as well. And even patients who don't have diabetes at all, their blood sugars are starting to go off 6 to 9 months before diagnosis as well. We looked at about 40 parameters, the papers published. But we've also were able to demonstrate 1 to 2 years beforehand that their bone marrow function was starting to diminish as well. So, we could kind of clinically see just from healthcare records in primary care, where, patients first interface with a doctor, that actually there are opportunities for earlier diagnosis. I'm not going to dwell on this point too much, but, in terms of better diagnostic techniques, yet again, this is a paper we had published recently as well. But actually, we know that cancers secrete material. And this was a really cool piece of work I did with a colleague who developed a new sort of chemistry to detect the modifications on circulating DNA. And this is something called a PSA plot. And this was a proof of principle study. But it was quite clear that actually it was very easy to discriminate stage 1 and 2 pancreatic cancers, which all these patients were, from matched controls such as pancreatitis and cysts. We've just recently appointed an outstanding clinical fellow where we're going to be looking at this in about 400 patients plus. Now, I think Hemant hit the nail on the head here. And, I'm not, someone who's that eloquent with my analogies, but I kind of think that the issue of pancreatic cancer lies in the chocolate chip analogy, where actually we're giving chemotherapy to these chocolate chips, but they're not the majority of the cancer. What's the majority of the cancer is this cookie dough, which effectively, as Hemant said, is, fibroblasts, the, proteins, immune cells. So, there's many groups working on this, and, my group doesn't really study stroma, but in my clinical job, I am a drug developer, and, we know that, the most ubiquitous pathway in the stroma is the TGF-beta pathway, which is a developmental pathway that gets re-engaged in cancer development. And, this is probably the only phase 2 study that's led on to a phase 3 internationally, which is quite a depressing situation that there's only one phase 3 trial in pancreatic cancer worldwide. But it leads us hope that this may yield results. So the phase 2 results come out later on this year. But then it actually asks us, actually kind of poses the question that is this really the way we should be doing drug development? Because, if we're having all these negative phase 1, 2 studies, and they're not really leading to phase 3s, and the phase 3s are negative, then surely we need to think about this. So this is kind of what my group at Oxford has tried to tackle. And the way we've tried to tackle it is kind of studying using big data techniques, the actual primary tumor. So this was using publicly available information that we took, so these are patients whose tumors, through both 2 very well-known consortia, were sequenced. And what we did is we overlaid the signatures of immune cells on the actual so we call these the transcriptomes. So we've, sequenced RNA. And what we could see is that there are patients where actually they seem to have more enrichment for what we call innate immunity. And then there are patients who seem to have more enrichment for what we call adaptive immunity. And, you know, to cut a long story short, I mean, these are just from patients who have had an operation. And at this time point, they were really getting either gemcitabine as adjuvant chemotherapy or no chemotherapy. And there's already a significant survival benefit just from having T cells in your tumor. So this kind of led us to the question of what those T cells actually look like in pancreatic cancer. I could appreciate that I'm probably going to go into quite complex immunology, and I will try and make this quite understandable, okay? I've only got one slide on it, luckily. But so let me just row back a bit here and just talk about immunotherapy, because there's been quite a lot of excitement in medicine about immunotherapy. And, you know, over the last few years, I think every patient I've seen wanted immunotherapy. When we talk about immunotherapy, we're talking about something very specific. And we're talking about something called checkpoint immunotherapy, okay? So what this is when T cells, which are the most advanced immune cells in the body, go to attack a cancer, and the cancer itself puts an artificial stop sign on it, okay? And essentially, a couple of scientists, discovered that if you actually drug this stop sign, it lets the T cells kill the cancer. So, we call this PD-1 checkpoint immunotherapy. And essentially, that particular type of immunity works by the more mutations a cancer has. So the more mutations you have, the more likely you are to form abnormal proteins, which we call neoantigens, to form an immune response. So this reaction normally happens in the most heavily mutated cancers, which are melanoma and lung cancer, but we also see in kidney cancer and esophageal cancer. So if your cancer is not that mutated, you don't really get this phenomenon. There is an exception with immunotherapy, with renal cell cancer, but I won't go into that in detail. We talk about the 1 in 200 patients in pancreatic cancer who respond to immunotherapy. They've got something called Lynch syndrome, which is a failure to repair your DNA properly. So when you don't repair your DNA properly, you get a lot of mutations, and that causes an immune response, hence why we could use checkpoint immunotherapy. So that was a quick primer on checkpoint immunotherapy. Interestingly, I actually met one of the guys recently who discovered the concept of checkpoint immunotherapy, and he won the Nobel Prize for it. There's a guy called Jim Allison. Interestingly, he plays in a band which is actually called the Checkpoints. I thought that was pretty cool. So let's go back to this. So interestingly, we've done a study where we actually identified the phenotypes of T cells within pancreatic cancer. And, what we did is we decided to map all the known checkpoint molecules. And actually, there's two types of checkpoint molecules. The ones we talk about are inhibitory molecules. The two best known ones are PD-1 and CTLA-4. We also looked at stimulatory molecules as well. So just for ease, I've put the inhibitory molecules at the top and the stimulatory molecules at the bottom. This is a technique called site-off. And just to cut a long story short, what we found is that CD8 and CD4 T cells within pancreatic cancer on the whole are senescent and don't seem to have any sort of antigen response. But what we have found is we found quite an active group of T cells within the same disease. And these are what we call regulatory T cells, which are implicated more in autoimmune disease. And actually, pancreatic cancer has really high levels of activity of these Tregs. And interestingly, they're completely loaded with checkpoints. So, they're high for something called TIGIT, ICOS, CD39, CTLA4. I won't go into the details of those, but in our point of view, this is a really interesting therapeutic angle to take. Now, I'm not going to go that much more into this because I think you guys have had enough immunology for one night, but this is something that that's going to the journals shortly. But we've actually managed to now develop quite a large compendium of immune cells within pancreatic cancer, and we've probably actually done the largest ever single cell experiment within pancreatic cancer. And we've identified a whole host of cells. I'm not going to go into what these cells are, but there are a lot of interesting biology there that we're exploring, especially along the myeloid cells. And one thing just to note is, yet again, when we look at checkpoint activity within this, yet again, they're all around the Tregs, but it also shows there's another interesting type of T cell that we completely missed with our site of experiment called a gamma delta T cell, where there seems to be a lot of activity there as well. We've also looked at something else called cytokines, and we could see that actually there is very high cytokine levels on the Tregs as well. Now, I'm going to just leave you with one further point, and I think genuinely, so this is new work. It's probably the first time actually I've ever shown this work, so it's cool. So what it is the new types of technologies we could use to study cancer. Okay, and this is a patient that was resected from their tumor in Oxford, and we were able to do what we call spatial genomics on it. So what's cool here is this is a patient who's been resected, it's gone straight into formalin, we've put it in the path labs, and now we've taken this out of the pathology labs, and the pathologist has been able to look at this. So they've looked at this particular section. We've been able to sequence this bit of tissue, and what we're able to do with this tissue is actually start identifying cell populations on this. So here you can see the cancer cells. I mean, you probably don't need to be that much of a pathologist to see there that's cancer. But what you can now start seeing is where the fibroblasts are and where the T cells sit. There's no way you could see where a T cell sits there. But we're starting to get that resolution, and we're actually, here we've been able to identify about 30, 40 different cell populations here. But then here's the clincher, okay? So this is another piece of tissue from the same patient. And what we've been able to do using that same technology is actually identify almost little neighborhoods of cells and where they sit. So, you could probably see there's the fibroblasts. Here's a neighborhood where fibroblasts and macrophages sit together. Here's another neighborhood where macrophages sit together. I don't think you could really work it out just from the trained eye, but from sequencing, we're getting this. And what we're now able to do is discover new biology in this cancer. So here, what we've done is we've run what we call a receptor ligand interaction analysis on this. And here's one particular receptor ligand, which I can't name on this particular talk yet. And what you can see is on this particular part of pathology, you could see that there's some ligand here, there's bits of receptors here, and there's actually all this coalition of receptor ligands. And actually this receptor ligand coalition seems to sit where the fibroblast macrophages are sitting. And this particular interaction hasn't been described in pancreatic cancer before. It's actually a new sort of level of investigation that we're doing. So that's kind of where we are. So this is kind of my final slide. I've not really, as I said, talked about chemotherapy because it's not great. But I think what I could hopefully have convinced the audience is that actually there's a route here for drug discovery within pancreatic cancer. And instead of running these big complex studies, I propose something that Krish had discussed. We're actually, you can tell that I drew this slide because the stickmen instead of really nice pictures. But essentially, you get 5 to 10 patients, give them a novel therapeutic, and you resect that patient's tumor after 2 to 3 cycles of treatment. You know, we're able to do systemic analysis with ctDNA immune cells, but actually with the tumors resected, we're able to really look, you know, biologically at if the drug has worked or not. If it hasn't worked, we don't really have to run a phase 2, a phase 3, and spend $1 billion plus developing that drug. Whilst actually, if that biology has been perturbed, it's telling us that actually we should be persevering it. So we're doing a proof of principle with this, where we're doing this with 30 patients treated with FOLFIRINOX. And, you know, we'll get those results sometime next year. And yeah, that's kind of about it. And I work with a lot of fantastic people in Oxford, including students, postdocs, other investigators. The final half the talk is a huge collaboration I have with the pharmaceutical company Bristol Myers Squibb, and there's been fantastic folks there, and the pathology support has been through Aachen Maastricht. So no, thank you very much for your time.
Thank you. Wow, we covered a lot of land, a lot of really interesting stuff there. So we've got some microphones. It'd be great if you could use the microphone, because we are recording this event and we will put it online in a week or two's time after we've edited it. Any questions from the audience so far? Hands up. So could you, gentleman there with the grey jacket? Just whilst the mic's going,
Hello.
CT scanning for diagnosing pancreas cancer, that's still the best way to diagnose it? And so should we be having CT scans as screening for pancreas cancer? It's the only way you're going to detect it early.
Yeah, I mean, I think that's
It's not a
a
screening
real
tool for
mindful.
sure.
Yeah.
Expensive
Yeah,
and
it's too
X-ray
expensive,
exposure.
got radiation,
Yeah.
and the pickup rate may not be as good, because you will detect a lot
What
of
about high-risk patients with a strong family
high-risk
history?
patients. There are a lot of trials going on to understand whether an MRI scan or an endoscopic ultrasound may be the best thing.
Right.
But you have to identify the high-risk population.
Sir, just
let
tell
me
us who you
congratulate-
are. First, tell us who you are, yeah?
I'm Dr. Ravi Joshi. I'm an anesthetic consultant.
Right.
And first of all, I would like to congratulate all 3 speakers today, Mr. Menon, Professor Kocher, and Sivakumar, for excellent and in-depth presentation about the pancreatic cancer. I have been at the head end to anesthetize the patients who had this dreadful disease. Some of my patients were my own colleagues. And in spite of excellent anesthetic, surgical, and postoperative care, I noted that none of them made second year after the surgery. So the question is for Professor Menon, Dr. Menon. You mentioned that only 15% of the tumors are resectable or operable. So I would like to know what is actual survival rate after successful surgery and postoperative care?
Gosh, okay, so I think as we've heard from the 3 talks, yes, the proportion of patients who are resectable are very few, 15 to 20 out of every 100. But the determinants of whether they actually survive beyond 5 years are how aggressive their disease is in terms of the biology. Is there invasion of the lymph nodes? Is there invasion of the nerve plexus? Is there vascular involvement? If you got all those bad prognostic features, your recurrence is very likely to be within the first 18 months. Now, as we heard, the biggest challenge is getting good chemotherapy to actually control the disease after you've done the surgical resection, or better still, if you know that this is a bad prognosis tumor, you give them the chemotherapy in advance to try and control the disease before you do the surgical operation. As you've seen, the operation hasn't changed from 1934 till now. Bit of tweaking here and there, but otherwise it's the same operation. So surgically, we know what to do, but it is the oncological side that we need to get better. So in answer to your question, there's 5-year survival. With all the bad features, will be about less than 5%. So, but if you want to get to the 20% and the high 20s, it is all going to be the neoadjuvant chemotherapy, stratifying the correct patients you want to take on for surgery to give them the best outcomes.
Yeah, no, I mean, I would agree with that. I mean, I have to say, I mean, I'm actually a bigger believer of actually trying to give neoadjuvant therapy for everyone, actually, because there's this whole, it's actually easier to give triple chemotherapy before the resection, and then we get into this ridiculous situation where after a resection we almost suboptimally give chemo. So and actually we've actually seen, even from our own series, that actually with triple chemotherapy we're seeing a 10% complete path response, and these patients in the long term actually get on and do really well.
Yeah, surgeons don't often concur with oncologists, but I'm going to concur with them absolutely on this. I think there's no question there.
Thanks very much for that.
Thank you. Just pass the microphone back. And the reason that we're not seeing good responses to chemotherapy, is it that desmoplastic reaction you get around the cancer cells so the chemo doesn't get into the cells where it needs to be? Is that one reason, or is that a simplistic view?
Yeah, no, I mean, I think it's a simplistic view.
Mm-hmm.
Sorry.
I'm just a simple surgeon.
No. I actually think that part of it, was the fact that you're right, the desmoplastic stroma, isn't really a chemotherapy entity. Chemotherapy was invented to attack cancer cells, and when most of the cancer isn't cancer, you probably need some other approach.
Satya, you're the man that organised this whole meeting. So a comment from you, and you're the man that's also removed an awful lot of pancreases over the time at the London Clinic and elsewhere.
Thank you. Congratulations to all three of you for such nice lectures. Really captured the whole field in such a short time. I think there is a difference between being realistic and then being depressing. I can be realistic about the state of the world, but I can still be optimistic about the state of the world. And that's how I feel about pancreatic cancer. As Krish says, we're still doing the same operation that was devised by Whipple in the 1930s. But we are so much slicker at doing it. We do it better, we do it faster, we look after our patients better, we get them through the operation. When we have complications, we pull them through the complications. So surgically, we're a lot better. And although Siva says that, the chemotherapy isn't great, I still remember when we had just 5-FU, which was like piss.
Yeah.
And
I was too young.
And now you've got drugs which at least you can see a response.
Correct, yeah.
And I'm looking forward to newer drugs, newer trials, new adjuvant therapies, and getting those survival rates up.
Right.
So I think I'm optimistic after a lifetime of being in the field, which means either I'm perceptive or very stupid.
And early detection, we heard about the idea of looking for cancer cells in the tissues. Any thoughts about that? I mean, is that something that's going to become clinically available?
Well, I think
soon?
so I think in general the
sort of cytology.
So especially circulating tumor DNA. I mean, I think it's already here. So I mean, anyone in this room could go out and buy a Galleri test if they want to, which captures methylated circulating tumor DNA of about 50 cancers. Whether it actually provides any sort of benefit to the patient is still, in question. And I think, the idea that we could detect these cancers at a meaningful stage. But actually, just to go on to that point about early detection, I think one of the things is that there are high-risk populations, and actually the majority of patients who have pancreatic cancer have some form of high risk. And I think we've got to get better at capturing that. So I think diabetes has definitely been captured a big issue. Cysts have, pancreatitis has, and I think what I would like to probably see is actually augmenting that with other tests such as circulating tumor DNA, rather than just having a random circulating tumor DNA test when you're symptom-free. I don't think it's particularly that useful.
I think just to answer that in a very simplistic way, I think what people like us have to do, which we do regularly in the November month, or not just November, but throughout the year, is educate the general public and the general practitioners of simple tests that can be, now obviously it was beyond the scope of my talk. Commonest thing that people come with is bloating and change in bowel habit. It's not change in bowel habit, it's actually steatorrhea, which is a lack of pancreatic enzymes.
Right.
They get investigated by colonoscopy, and that's normal, so they get discharged, only to pitch up 2 years later with obstructive jaundice and then be diagnosed with the pancreatic cancer. So it is about understanding the symptomatology of pancreatic cancer and at least picking it up at that point where you can actually meaningfully do something to improve their outcomes.
What about the genetics of pancreas cancer? You talked about the Lynch syndrome, but I have a colleague who's BRCA2 positive, and he's had a pancreatectomy successfully, I think by Sacher actually. So what about the genetics? It runs in families, doesn't it? So that would be one risk, but there are other specific mutations that you could look for that would put people at high risk?
Yeah, I mean, should I take? Yeah, I mean, so there's probably about 5 to 10% of patients who have a genetic predisposition, and they probably fall into two groups. The more significant group is what you said, the BRCA2 mutated patients. Well, actually, they come under a family of genes called the homologous recombination genes, which I'm sure some of our medical students are very well versed with. But and they affect DNA repair. And interestingly, these are the patients who seem to do really well with platinum chemotherapy. And then the smaller group is the Lynch patients as well.
As we increasingly understand the biology of the disease, you realize you can understand there are familial pancreatic cancer which go outside these things.
And lifestyle changes, smoking, diet, anything that we could do to reduce our risks of getting this?
Smoking is the only recognizable risk factor which is very well validated. I don't think there are any other risk factors which are very well validated.
Georgia, the lady, one of our regular supporters of the RSM.
Thank you. Good presentation. One of my questions is about chemotherapy. What about radiotherapy? Can we apply radiotherapy to pancreatic cancer, and if this is helpful, or perhaps radiolasers to dissolve the cancer? But my specific question is radiotherapy. How it's about?
Yeah, so I'm not a radiotherapy doctor, but I do work quite closely with colleagues who administer radiotherapy. Now, in the localized setting, there have been several trials which I think have shown that radiotherapy isn't particularly that useful, though the evidence is, probably a bit marginal. I do think there is a role for radiotherapy personally, especially in the metastatic setting, but yet again, these haven't been validated by trials. But I think actually, in my eyes, it's a definite tool in our armory, but I think part of the reason it's not well valid, there's no evidence, is because I don't think we've run enough studies with it. I don't know.
Are there newer forms of radiotherapy getting it targeted better, delivering the dose more effectively to pancreas rather than radiating all the surrounding organs which you saw, which cause the side effects, may be useful? Trials have to be done to understand this. So far, trials have been negative, but we hope as combinations come where we can target the stroma more effectively, maybe radiotherapy will become more effective. So there's hope for the future, but at the moment, radiotherapy is not advocated for most patients, but for a select few.
I think the other place where radiotherapy is currently used is where you've done the operation and then you get a margin positive resection. After having adjuvant chemotherapy, some oncologists do offer radiotherapy as an adjunctive treatment. But again, the evidence base for that is very little at the moment. And I think there are a lot of new technologies coming out in the market. You heard about one, nanoknife, but all of these are under evaluation. So yes.
What about charity support for pancreas cancer? Pancreas Cancer UK is a charity, is that right? And they're raising enough money to provide you guys with the funds to do the research that's needed?
Pancreas Cancer UK does fantastic advocacy for and provides a very good support line for pancreas cancer patients. They also do research. Pancreatic Cancer Research Fund is another charity. Cancer Research UK has identified pancreas cancer amongst the 4 cancers with large unmet need, and they're trying to focus more research on pancreas cancer. And there are a number of centers across UK which have been identified as pancreas cancer centers for research excellence, BARTS being one of them. So a lot of research now undergoing or is being undertaken in pancreas cancer.
But it's nearly time to, oh, the question there, yes, sure. Could you bring the mic round? Yeah. Otherwise we won't be able to hear it on the recording. Thanks, Georgia.
Hemant, just wanted to ask you about OncoCell treatment. How is that developing and what's the success rate on that?
So OncoCell is a fantastic treatment for patients with locally advanced pancreas cancer. It's a way of developing...
Just explain that to the audience.
Yes,
what that is.
of course. It's a way of developing or giving radiotherapy in a targeted manner into the pancreas, and you deliver that radiotherapy with an endoscopic ultrasound guided placement, and that has to be done in conjunction with chemotherapy. So it's not radiotherapy alone. I think it's very good results from a single arm phase 2 study, and registry is now open. It's open at London Clinic, so patients are welcome to participate in that.
I think can I make one couple of comments? I think just from what Satya said, from the doom and gloom side of things, I think the only positive in all of this is the cystic neoplasms, which we have not touched on, because there is a group of patients that we've started to identify in the last decade or so, where if you pick up the high risk patients with these cysts, these are the ones that transform into adenocarcinomas later on. So if you pick them up early and you've got a clear algorithm of when to intervene surgically, you can actually save some of these patients going into the locally advanced or metastatic pancreatic cancer stage. So that's the positive. I think the take-home message, even though we have good local treatments, is I think most of us know pancreatic cancer in the beginning is a systemic disease at the outset. I think if we get that fundamentally right, we know why chemotherapy is going to be so important going into the future.
So that's the way ahead. Well, thank you so much. We've got drinks outside, so you'll be able to talk to our speakers there. So have a round of applause. Thank you. Just 3 announcements, because we like to have these public-facing lectures about 1 a month. And on the 28th of March, we've got the Jeffcott lecture with Sir Patrick Vallance talking about science matters. On the 20th of April, we have the Dangor lecture, Axel Heitmuller talking about global medicine. And then we have the Stevens lecture on the 15th of May, where Matthew Taylor from the NHS Configuration, brilliant speaker, is coming. So do come along to those, totally free, drinks afterwards, and it's time for drinks now. Here we go.